Hello, everyone. Welcome to today's Preventive Medicine Grand Rounds for January 11th, 2023. Today's topic is going to be using electronic health records to improve population health, presented by Samareen Shami, Manager of Population Health Plan of San Mateo. The findings and conclusions in this presentation are those of the presenter and do not necessarily represent the official position of the Centers for Disease Control and Prevention. For those interested in obtaining continuing education credits, you can go to the Training and Continuing Education tool on CDC. Information has been put into the chat about the access course code. Also, information on closed captioning, live captioning has been put into the chat. I'm now going to open it up to Samareen to give the presentation. There'll be an opportunity to provide a question and answer at the end of the presentation. Samareen, the floor is yours. You're on mute.
Yeah, thank you so much, Mike. I hope everyone can hear me. Welcome today to the presentation, using electronic health records to improve population health. I will really, the purpose today of today's presentation is really to discuss how health plans, such as mine, I work for the health plan of San Mateo, which is located in South San Francisco, how we use electronic health records and EMRs to improve population health. Population health approaches often involve the use of data and analytics to identify and track key health indicators, such as rates of chronic disease, infant mortality, and life expectancy, and to understand the underlying factors that can sort of contribute to these indicators. And this information can be used to guide the development and implementation of interventions to improve the health of a population, which is really what I do at the health plan. This presentation, I have to give a little bit of a background, really came about from an article that was passed around our population health training in place program group, and I'm a part of that class for this year. And that really discussed physician burnout from having to use EMRs, electronic medical records, and electronic health records. And so I will be touching on that a little bit because, you know, that part of using these records cannot be ignored. But what I really wanted to emphasize, and what I stated as well in that sort of email chain, was the importance of this information for population health. And, you know, the digitization of these records, and even at a small health plan like ours, we're able to do a lot with the data, especially if we are able to have data talk to each other. So I think of these examples that I'm going to provide you today as a small blueprint of what is possible in population health if we achieve that ultimate dream of the perfect interoperability. But I don't want to undermine also how important the role of the provider is in entering the data, and how any solution that we look towards interoperability must also make that portion easier. I'm also not here to say that you know, programs like Meaningful Use, which are quite controversial, were great. Just that where we are now and what we plan to do with our data and what we can do with our data is really important, and we can use previous programs to kind of learn from the past. I do also want to make a quick differentiation between EMRs and EHRs. So electronic medical records are digital versions of a patient's medical history, which include information such as diagnoses, test results, and treatment plans. And EMRs are typically used by individual healthcare providers, such as doctors or nurses, to manage patient care. In terms of EHRs, which is the term that I'm going to be using, and perhaps I will move interchangeably between EHRs and EMRs, but EHRs are typically more comprehensive and include information from multiple healthcare providers and organizations, while EMRs can be specific to a single organization. So this is the kind of agenda for today. I do want to talk a little bit about electronic health records and how their prevalence is, you know, how they are everywhere and how we kind of got here so quickly. I then want to talk about some of the benefits and the drawbacks of electronic health records. And then really the crux of my presentation is showing you how we at the Health Plan of San Mateo use that data in combination with other data sources to really make this data more meaningful on a population health level. And then, at the end, when you're talking about EHRs and when you're talking about data systems such as ours, you can't really ignore interoperability. So I do want to talk about that and its potential for population health as well. So, how did we get to where we are? I thought this would be a great start to sort of set this up. So I'll just give you a second to read this quote. And really, the idea here is that the more data that is available digitally, technically, the greater the potential for improvement. However, of course, sometimes having all this data online creates more problems rather than solving them. So, I just wanted to set that up, and plus it helps break up this presentation a little bit. I will try to include, I have tried to include some quotes here and there. So this next slide looks at a little bit of sort of how we were placed in 2009 and where we are currently. So in terms of meaningful use, which really began in 2009 with the enactment of the American Reinvestment and Recovery Act and the Health Information Technology for Economic and Clinical Health, which is the HITECH Act. With the passage of the HITECH Act, the sort of medical software marketplace was changed. Prior to this, things were moving along pretty slowly, and I'll show that to you in my next slide. The only kind of innovations that were out there were things like the VA's VISTA program, and the HITECH Act authorized roughly $36 billion worth of incentives for the use of health information technology. And ultimately, that translated into $44,000 for Medicare eligible or $63,750 for Medicaid eligible providers as incentives, which really created a rush to adopt qualifying systems. Everyone, it seemed at that stage, was really working on this incentive eligibility. Of course, when something like that happens, many vendors sprung up. Some were designed without much thought, and the user experiences were also very poor. If you start looking at what physicians were saying at that time, there's so much out there on how these templates that the programs offered were poor. Physicians did not appreciate the time. They then had to start spending on these EMRs. But this was really a true carrot and stick approach with a combination of incentives for compliance and penalties to reimbursements for non-compliance. So this really drove what happened in 2009. And there was also an increased focus on the capture and standardization of data, which also elicited some reluctance from providers. And again, as I said, you can find many articles out there of physicians who were just not getting enough time for patient care and were having a difficult time adopting these standards. Incentive payments began in around January 2011. And according to the most recent EHR incentive program summary report that I was able to find, 118,819 eligible providers and 2,320 eligible hospitals received a total of approximately $5.4 billion in incentive payments, which translated to about $18,600 and $1.37 million per participating provider and hospital, respectively. So once this data started coming online, and what is currently going on as well, there were concerns about patient care and transferring this data to consumers, and everyone kind of understood over time that this data didn't really speak to each other, and patient access to data became a key component of what happened next, as well as guidelines and mandates on data interoperability, which have continued. And these largely have focused on first sharing data with patients and members, and second, trying to share that data with each other, with other health systems using things like the health information exchanges. So right now, many of the health plans and health systems are involved in trying to meet some of these guidelines And there's so many of these if you start looking through them. So right now there is, as I've said in this slide, there's the TEFCA, there's the CMS final rule, and the ONC has really released a 10-year roadmap for achieving interoperability, which I'm going to be talking about a little later. But the CMS final rule, for example, is really focused on giving patients access to their data. So this next slide really concentrates on how this kind of boom took place, which is really interesting. I thought this was a great slide, which showed that, as of 2021, nearly 4 in 5 office-based physicians and nearly all non-federal acute care hospitals have adopted a certified EHR. And, the Office of the National Coordination for Health Information Technology, ONC, also, this is, I believe, this is where this data comes from. So this is substantial progress. If we go back to 2011, only about 28% of hospitals and 34% of physicians had adopted an EHR. And as you can see, the incentive payments were remarkably successful in terms of adoption. However, as many people will report, and of course I will as well when we get into the data, not everything worked well, and there was definitely some questionable things going on in terms of these incentive payments. I'm not going to go into all the negatives, but one thing I did want to say is that it's the way that people kind of react to these incentive payments is mixed. But one thing that I think we can all agree on is that things would not have happened this quickly had it not been for the HITECH Act and the incentive payments. So, of course, with speedy adoption comes significant issues. It has indeed led to some of these, which I've mentioned here. It's raised concerns about data security. As more and more patient information is stored electronically, there's a greater risk that it could be accessed by unauthorized individuals. This has led to concerns about the potential for data breaches and the need to implement strong security measures to protect patient information. One of the other main problems has been the high cost associated with implementing EHR systems. Many healthcare organizations have had to invest a significant amount of money to purchase, install software, and then train staff on how to use it. And of course, this puts a strain on budgets and has led to some organizations being actually unable to afford EHRs. Another issue with adoption has been the fact that they can be complex and difficult to use. There is low-end user satisfaction. Many healthcare professionals have had to spend a lot of time learning how to use these new systems, which takes them away from patient care. In addition, some have been prone to errors and glitches, which can cause problems for healthcare providers, especially if there's no IT support. And finally, the two areas that I want to talk about and I kind of touched on today, which is the siloed data and the physician burnout. The data as it exists, and I'm going to talk about how much time we also spend at the health plan, really trying to clean up the data and have it speak to each other between all our different providers as well as our FQHCs in order to, I was talking to other people as well, in order to access some of the prior patient data from different hospitals. Sometimes physicians have to send in faxes for permission. They have to get permission from various patients. So, these are all significant issues in terms of siloed data, and of course, physician burnout, which there are many articles, and really what prompted this presentation. There's much evidence that EHRs can contribute to physician burnout as well. So this next slide really kind of looks into that. And here we're looking at the hours per day that physicians spend outside of normal office hours documenting clinical care in their medical record systems. So you can see that some are spending more than 4 hours. Of course, even 1 to 2 hours is a bit too much, and that's just even that I believe is a significant contribution and cannot be taken lightly. Then, there's also, if you start looking at physician burnout studies, there's definitely an increase post 2011, and it is a significant increase. And you can also, there's also a lot of studies on what exactly happens There's one North Carolina orthopedic clinic study where the adoption of Epic's EMR increased physician documentation time by 230%. And according to this article, increased labor costs per visit by 25%. Some studies have indicated that some physicians spend more than 6 hours a day on their EMR. And of course, this, which is known as, I believe, pajama time, is unacceptable to physicians and is a considerable factor that we have to consider when we really rely so much more on EHRs. And really, you'll see in my presentation, it's such a key component of the data that we use. It's unfortunate that it doesn't work well for everyone. Of course, we cannot go back to the way things were either. EHRs do have numerous advantages, and I've tried to list some of these here. And there's memes upon memes about about what EHRs have done, but definitely documentation that is legible is one such advantage. Reducing errors. EMRs can help to reduce the risk of errors in patient care, such as prescribing the wrong medication or failing to follow up on test results. EMRs also allow healthcare providers to access the patient's complete medical history in a single place, which can help to improve the quality of care that they receive. EMRs can also help streamline the process of managing patient care, reducing the need for paperwork and making it easier for healthcare providers to access and update patient information. And I spoke to so many people who have worked with EMRs, but even though many of them did dislike working in them, there's so many advantages. The quality improvement metrics and the ability to track throughputs. This is also something that I've worked on in the past at UCSF, where we were looking at patient discharges and how to improve that. Patient access to data is also something really important. Having patients being able to access their data could be the future of sort of patients understanding their own care. Identifying care gaps, again, is something that we work on at the health plan with our providers, trying to show where the care gaps are and what the data shows. But really, the focus, of course, in my presentation is going to be on population health. And so really this next part is really what I want to show all of you, which is how our health plan, which is very small, and I will go into that a little bit as well, how we use EHRs in combination with other data to really develop a 360 view of our population. And so the next quote, I wanted to really talk about how the best recommendations are really based on the best available data. So the better the data, of course, the better our view on what our population looks like. So HPSM, I just wanted to provide you with an overview so that it gives you some context of where I work and what we do. The health plan of San Mateo is located, it's a pretty small local California health plan. Our programs cover 1 in 5 San Mateo County residents, which is where we're located. San Mateo County is just south of San Francisco, and our main programs are Medicaid and, of course, Medi-Cal, Medicaid, which is known as Medi-Cal in California, and Medicare Medi-Cal. So those are the individuals who are in the duals program. The Medicaid program covers about 121,000 lives. And then for those individuals who have both Medicaid and Medicare, that's about 9,000 folks. We also have some various other smaller programs, which cover a few other people. So overall, we have about 150,000 lives that we take care of, and our membership is pretty diverse. Our Medicaid population is actually pretty young, with more than half of them under the age of 21, and they largely identify as Hispanic. And our Medicare population, which is, of course, older, largely identifies as Asian and Pacific Islander. And I think it's really important to kind of discuss the regulatory climate under which California health plans are currently working. The state is the Department of Healthcare Services, DHCS, is always innovating and transforming the Medi-Cal delivery system, and is currently rolling out CalAIM, which is the California Advancing and Innovating Medi-Cal program, which is really what they consider a long-term commitment towards a more population health approach to Medi-Cal within California that prioritizes prevention and really whole person care. The goal of the program is to extend supports and services beyond just regular healthcare directly into these communities. So according to the website, they state that their vision is to meet people where they are in life and address social drivers of health and break down the walls of healthcare. And they really want to give members access to services that address both their healthcare, their physical, behavioral, developmental, dental, and long-term care needs. And a lot of this work is being done through health plans. There's also interoperability requirements from the state and CMS, and also a very big sort of push to improve data and really provide more social determinants of health data. And this is really an important context to put this work into, because we're constantly being told the new population health approaches that are coming down from the state, and so we're constantly having to adapt to those, as well as the amount of funding that is now available for population health, as well as the programs and services that are available are considerable. And it's really a very exciting time to be working in population health in California, because of this focus on all these considerations that are such an important part of healthcare. So, as I said, I work in population and health for HPSM, and we work very closely with our health information department, which incorporates both our informatics and our data analytics department. And population health, as I said, involves collecting and analyzing data from all these sources to understand the health needs and characteristics of the population. And as I mentioned, we really try our best to sort of develop a 360-degree view of our membership and our members. And so these are just some of the common data sources that we use here. So I'm going to just touch on a few of them. Claims data. So this data comes from insurance claims made by patients and really can provide a great deal of detail about the utilization of healthcare services within the population. There's also the public health data. This includes data from government agencies and public health organizations, CDC, on the health status and needs of a population. So we will combine that when needed. Clinical data is data that is collected by healthcare providers during patient visits, such as vital signs, lab results, and medication lists. We also have access to pharmacy data. That has changed a little bit for the Medi-Cal portion, because it is now done by the state. So we don't get our data needs our data, the way the data comes in has changed since this carve out, but we still have a lot of information on prescriptions and particularly on drug pickup information. There's also patient generated data. So this includes data that we collect from patients. If we had wearable devices, we would be able to collect that data. Unfortunately, we don't have that, but we do have surveys and also patient reported outcomes as well. And then the social determinants of health data, I just wanted to talk about that a little bit. The way that we collect this data is really, at that point of care. And this includes all the data that we consider when we talk about social determinants of health, which can impact a person's health, such as housing, access to transportation, education, whatever it is that the provider is able to collect. And we really collect this, and we plan to collect this increasingly through Z codes. And we also have a screening tool that we will be sending out to our providers so that they're able to screen for these things on a consistent basis. Our SDOH data is not perfect right now, but it is always getting better. And especially particularly one thing that we're looking for is that housing data, because many of our members face some struggles in terms of having housing. So another thing that I want to note here is that all this data is collected at different points of care. So this does add a great deal of complexity and layers to the work that we do in population health in tandem with our informatics teams as well. This next slide kind of looks at the challenges of working with this data. It's not perfect. In fact, it's far from perfect. If what we aim to do is get a 360-degree view of what is happening, we have to kind of combine this data in various ways. So data quality is an issue. We have to ensure that the data is accurate and complete. And that is a key challenge in population health management, even especially at the health plan. Data can be missing or incorrect, which can really affect the accuracy of the analysis and what we're able to do. So we spend a lot of time on ensuring that that quality of data is as high as possible. Data integration, of course, as I mentioned, population health data comes from many multiple sources, and this can make it very difficult to integrate and analyze. This can be particularly challenging when it's stored in different formats or systems. Data privacy and security, of course, continues to be an issue, as some of this data is sensitive and contains personal information. So when we're sharing data, we are very, very cognizant of that. And there's really strong sort of privacy and security barriers, I would say, that we have to kind of consider before we implement anything or work with any data. Data standardization, ensuring that data is collected and recorded in an accurate or consistent manner is important for when you're able to do analysis and comparison. Different healthcare providers have different ways of collecting and recording data, and that makes standardization difficult. We try our best to sort of help our providers with that and provide as much information as we can on how we would like data to be collected, but of course, a lot of it just is on our end, trying to clean that up and standardize it in formats that are usable for us. Data analysis, of course, there's some large data sets and they're not always that pretty. So analyzing this data can be complex and time consuming. And then the final thing that I wanted to mention really is that limited resources aspect. Population health management involves and requires significant resources, funding, technology, and with a small health plan such as ours, that's definitely a difficult thing to always get. Having all the great systems, they're expensive, and so we rely a lot on our health, our informatics department to be those experts in helping us analyze and clean up that population health data. So now that I've spoken a little bit about that EHR data as well as the other data sources, I really want to now talk about how we make contributions to population health for our health plan. So if you learn nothing else, please do concentrate on this slide. I really do want to talk about how this wealth of data, if it was perfect, especially, and if it was clean, and we assume we are able to clean it, and we try to make it as high quality as possible. There's so much that we can do with this data, and really it's such an exciting thing to be able to look at data and see trends. And so I will talk about some of these initiatives. I really could go on and on about all of these, but I want to show a few examples of what we do. So a lot of this data really helps us in public health and at the health plan to design and implement targeted interventions, which really address our specific health needs within our specific population. And more and more organizations are using, of course, population health activities to address things like chronic conditions, readmission risk, and really leveraging data to reach these populations. And I think that part of this is also to make this information also much more actionable. That's one of the things that we would like to provide with our data. And I will talk a little bit about how we try to do that with our providers. So these are the areas that I'm going to really talk about today, but that's not to say that many of these are interconnected. So I'm going to talk a little bit about how we aggregated data for populations and subpopulations when we were looking at COVID-19. I'm going to talk a little bit also about the risk stratification of members and how we use all the data sources that we get, and of course our EHR data, to stratify our members so that we're able to kind of give them the best care possible. We do also use our data for disparities analysis, and I really want to talk about what we do there. And one of the connections that I want to make today is also how we look at things from a population health perspective, but how we try to then make sure that we're making a meaningful impact on clinical care as well. So we try to do that as often as possible in tandem with our providers. And care gaps is another one of those examples. But these are the kind of 4 examples that I want to try to get into to show you what, even at a very small health plan, when the data speaks to each other, and when we cleaned up that data, what we could potentially do. And I think this is just a few things. There's so many other things, and larger health plans, larger organizations with better systems, I'm sure, do this even better. So in terms of the first thing that I wanted to show you is what we did in terms of population health during the pandemic and after. So I think that we can all recognize that the COVID-19 pandemic showed us a lot about the limits of what we can do within healthcare and the stresses that kind of exist within our health system, and the vulnerabilities that also exist. However, what I wanted to show you is what we did as a health plan and what we were able to do with the data when we worked with our partners. So here are 2 charts, and just to let you know, this is really based on vaccination data, but we also tracked the disease as well. We really tracked, especially in the beginning when we didn't have that much information. Now we know so much more. We were tracking who was getting the disease, and the populations that were getting hit the hardest in terms of death rates. And at that time, now we know a lot of what happened, but much of this was not known at the time. We really didn't know what was going on with our population. So we did spend a lot of time working with data and using the CDC data as well to verify what we were seeing in our population. We were then able to use that data on our members to really target the right populations when it came time to vaccinate. So this first chart that shows you the vaccination rates by tier on the left is really a composition of all the things that we were seeing in the population on who was the highest risk for adverse sort of effects of COVID-19. So we really wanted to make sure that our highest risk people were getting the vaccines first and early. So we had some risk tiering that we did, and risk tiers were determined by their chronic conditions, how many of those chronic conditions they had, what their main ones were, their age, their race, and their ethnicity. And we wanted to ensure that those members who were at those highest risk tiers 1 and 2 were really getting vaccinated first. And we're really doing a lot of this tracking on a weekly basis. And there was a time where we were seeing, it was not headed in the right direction. We saw that, and we figured out that it was because many of these appointments that were online were being taken over by other populations. And so, trying to then making sure that we had appointments for vaccinations that were exclusive to some of these older members or those members who are in risk tiers 1 and 2. Our data really helped us focus that. The other thing that we did, and you can see this on the other chart, is the percent. We were really able to work with our county in making sure that vaccinations were taking place at, or were available in all the areas in the cities that make up the county. And this was a really important part of what we did. I wish we had better SDOH data at the time, and I think it's really improved since 2021, but that would really have helped us. But we were able to break down in terms of both the cities as well as the providers, and really watch which providers had more unvaccinated members and which cities had more unvaccinated members. And it might have been something along the lines of having more clinics be supported by us so that they had support in terms of vaccinations. And sometimes it was working with our county to send some sort of mobile vans or just helping us spread the word to achieve better vaccination rates in areas that we saw had issues with access. And we have some SDOH data. Like I said, it wasn't the best then, and it's only improved. But it would have been, even better if we had better and better SDOH data as well. So that was just one of the many things that we did during the pandemic. Then I do want to talk a little bit about risk stratification and how we use all those data sources that I mentioned for risk stratification. So risk stratification is the process of identifying and analyzing factors that may increase the likelihood of a negative outcome or event occurring. So in the healthcare context, risk stratification involves identifying patients who are at higher risk for certain problems or conditions and taking steps to prevent or manage those risks. So risk stratification can be based on many factors. And here is a chart kind of showing how we do this at the health plan. So we risk stratify our members by, and we put them in high, moderate, or low risk categories. And we look at which is utilization management. So first we're looking at those users who are high users of healthcare services. And we're also looking at those users who have a higher acuity score. So now in combination with these two things, we come up with that high, moderate, or low. But what we also try to incorporate is those other characteristics. So it's not just their medical history, it's not that just their lab results and their outcomes. We're also looking at SDOH factors. We're also looking at what programs they currently qualify for. We're also looking at how engaged that they are with their PCPs, what their care gaps are, and we really try to use this information so that we can make informed decisions on how we develop our interventions for those members who have gaps, as well as what kind of services we need to provide for them. So just to give an example, if we look at those members who are in the high category here, they have high and high acuity. So those are members who have a high risk utilization band score. So that means they frequently access services, and they also might be in high cost services such as hospitals or long-term care facilities or skilled nursing facilities. They perhaps frequent the ED quite a bit. They have had probably a 30-day readmission, very likely. And so if there's like a 70% chance or more, and also this member probably has some severe non-behavioral health chronic conditions, perhaps ESRD or heart failure, and or the member has more than a total of 6 chronic conditions. So that's just some of the factors we look at, and then we combine all that data that we have on SDOH, the programs, and as I said, PCP engagement, and there's many other factors. For each of these areas, we are constantly relying on more and more data from providers. So the better data we have at point of care, we are asking the providers to do a lot of the work here as well. So I do want to acknowledge that. But what we try to do is really feed this big data back to providers, which is really an important part to help providers who don't know. Some providers know their membership really well or their patients panel really well, but we really try to help them understand their panel as well. And so once we've kind of risk stratified, we are then hopefully able to understand that population a little better. And it can help us identify patients who may benefit from interventions such as preventive care, lifestyle changes, or perhaps more intensive treatment. It can also be used to prioritize care and allocate resources, as patients who are at higher risk may require more attention or resources. So it allows HPSM to better understand its membership and assign resources accordingly. We also use it to allocate the appropriate case managers, especially to the high risk and medium risk groups. However, I think that all plans and all sort of organizations might have this risk stratification strategy. But what we try to do is we really try to use it to really understand our membership. And everybody at HPSM who works with this data will tell you that we look at complexity, but we are also seeing how well taken care of they are. So just because a member is complex, if they're in a lot of programs and we think that their case manager, they have a great relationship with them and they're interacting with their case manager, that person, although would be identified as high risk and will be a part of those programs, that does not necessarily mean that they need a particular additional thing, because we also don't want to just load them up with stuff either. there might be members who are actually pretty healthy, or at least that's what we're seeing, because we don't see them come in a lot, but that they might be homeless. So those people will then we will try to get them into housing programs. And a lot of what the state is currently doing in CalAIM is really helping those members. So what we try to see is across the continuum of complexity, what are the actual needs and where are the actual gaps? Are they sick? Or do they just need reminders to go in? But are they well, but are they, facing some housing insecurity? So where are the gaps in social supports? And we try to use this risk stratification to really understand our population and put them into the relevant programs. And we try to make sure that we're sharing this information with our providers as well. So that's really how we kind of use risk stratification. The next part that I want to talk about is what we do in terms of health disparities. So we can use our data to identify health disparities by analyzing patterns in the distribution and utilization of healthcare services, outcomes, and many health-related indicators. At HPSM, we do it in many ways, but I will illustrate sort of one way that we kind of do it. So first, we collect the data. And as I mentioned, we have overall membership data. We do, of course, use our EHRs. And we also have, in combination, all of that information kind of, we look at different metrics that either we have produced or the state has asked us to keep monitoring. So these are, the reviews that we do at that overall membership level data. Then we stratify based on the various demographic variables that we are able to stratify on. So race, ethnicity is one. Age, it might be age, it could be zip code, geographical areas. So once we've done that and we stratified, we try to look for any differences, and we want to make sure that any differences between the overall average and of those groups is actually statistically significant. And that's where we kind of, and this is just one of the ways that we highlight disparities, but this is the sort of quantitative way of doing that. And once we've found that statistical significance, we then know that we've identified some disparate subgroups, and that's kind of where we're going to target our interventions. So we, of course, aim to reduce those health disparities and improve the overall health of the population. So this next slide, it looks a little complicated, but actually it's not very complicated at all. If you kind of look at those indicators on the top, you don't really have to get into what they are exactly, but let's just say that these indicators that we have over here are just ways that we kind of track our population. People who are in health plans are probably very familiar with these. These are HEDIS metrics. But let's say this one has to do with asthma, then we've got diabetes, and then we've got some well child visits, as well as prenatal metrics. But what this data has shown us, and the process, through the process that I kind of talked about a little earlier, is that we consistently see within our membership one group that has has faced these disparities. And the kind of analysis that allows us to identify that and really look at that is based on all that data that I talked about earlier, as well as these EHRs. So once we find this, what do we do next? Again, it's about making that data meaningful. And this kind of analysis allows us to see what's happening, but then we really have to explore why this is happening. Where are these members located? Where do they live? Where do they eat? What is going on with them? And more importantly, which providers do they go to? Do they go to providers? Where are they impaneled? And we really use this data to figure out, for example, in this case, where our Black identifying members are impaneled and which provider we can kind of talk to and share this information with, so that if we do want to work on improving programming for these members, that we work very closely with our providers on that. We, of course, also have very strong relationships with our county, and we do feed this back to our county partners as well. So we don't just stop here with the data. We try to take this to its next level, try to find out what's going on with this population. And this is definitely an area that we are working on now in different ways. And of course, it's time consuming and it takes a while, but really helping our providers see those patterns is also important. And the other thing that I kind of want to mention is that we also take this data and we have a system that provides all this data to our providers, whoever wants to track it, whoever wants to see it. And we have incentive dollars tied to this as well to improve some of those gaps. But that's another presentation and another time. We help them close some of these care gaps as well. We have providers who use this data on an annual basis to make decisions on care gaps and the areas that that they are also going to work on. So, we try to make that information as valuable as possible for our providers as well. So another and a final example that I want to kind of talk about today is, what we do with some of this data that leads to actual clinical care improvement. We learn things at the health plan on a population level, perhaps. And what we want to do is break this down further by enabling some level of clinical decision support. So in this example, we began measuring who was going into the ED, right? And that's something that, we look at overall. And we were seeing emergency department visits for both asthma-related inpatient and ED visits. And of course, asthma is something that you don't necessarily, if we are seeing ER visits, there's something going on with asthma management that we want to get to the bottom of. So what we started doing is we first started calling the health plan staff started calling members who had poor asthma control, who were going into the ED, and asked them what the issue was, why they weren't either taking their medication or what was going on, why they hadn't contacted their provider. And one thing that we learned was that they really didn't want to talk to the health plan. They really just wanted to talk to their providers. And we found out that there were definitely transportation issues and things, but what they kept coming back to us with was, I want to talk to my provider about what I can do. So we realized that the steps that we had to take, we couldn't necessarily take directly with our members. In some cases, we are able to do that. So what we started doing was we first developed goals for the rates for asthma-related inpatient and ED visits using what we were seeing nationally in areas, where our benchmarks should be rather than where they were. And we developed a provider level intervention. So what we did was we developed a letter that was sent out to each provider whose member, we call them members, but whose patient had been in for an ED visit or an inpatient visit due to their asthma. So that letter really listed out, number one, the date of when their last ED visit or inpatient visit was, and was sent. So this letter was sent out to PCPs and was also data on their overall asthma control, which is a number that we do provide, and we have explanations of what that number entails. And we also added the data that we were getting from the pharmacy on their medication pickup. So what medications were they on, and really what had they actually picked up? So then this information was, of course, mailed or faxed. Unfortunately, I have to use the word faxed to the provider, depending on what they preferred. And it also provided information on what they could do once they got that letter and knew this about their members. So where, many of the things that we want to provide is, again, this actual tangible clinical care improvement. So if the member was a pediatric member, we let them know about the home visiting program, and we provided the referral form to help the provider refer their member to home visiting. And we gave them also a link to the new asthma action plan that we had developed. And finally, we also gave them tips on how to discuss or what to discuss in terms of medication with their members. And the pharmacy department was really a key part of providing that information as well. And what we saw from this was, first of all, the sort of feedback from providers was really great. Some providers were actually somehow incorporating this into their pager system. So every time they got a letter, they either sent an alert from the EHR or, there's some complex thing. Unfortunately, it's a letter, but there are, of course, negatives there. And what we saw was an increase in provider interaction between their members. So providers were then able to reach out to their members and say, hey, I saw that you had a visit, what's going on? We also saw an improvement in our asthma control measure that I talked about a little bit. And we also saw a reduction in ED visits over the course of this intervention. Now, was it all related to this intervention? No, it's hard to say that that was the only thing that was going on. The asthma action plan had been helping. We were really out there in the community talking about asthma, but the fact that these conversations were taking place is really a big sort of positive for the things that we were able to do that led to this improvement. So, I hope that I have kind of shared today with you some of the things that population health does with that digitized data. And so in summary, I just want to say that population health relies heavily on the work that clinicians do to enter data. But improvements in population health, as you've seen, are just not possible without this digitization. And digitization has really been a boon for population health departments and population health work, even though, as I said, it is certainly not perfect, and a lot of time is spent in understanding the data and what we need from it and what we can do with it. So now that I've kind of presented what population health does with all this data, I really want to talk a little bit about interoperability and the case for population health as a use case. And so my final quote, just to give you a minute to read that, but really what's important here, I think, is, all this data that does come through, if it is not well thought through, what we can do with the data, perhaps as what the past shows us, if you don't know what you're going to do with it, then it becomes really difficult to know what the future should be as well. And, as I talk through my slides, I think you can agree that effective population health management will just ask for more and more information and better data. And a lot of that does come, unfortunately, from that point of care. So, I tried thinking about, right, if we are moving towards better data and the data speaking to each other, what can we do for both those people who are collecting the data and then eventually for people using the data so that we do have that 360-degree visibility. So, there are some short-term solutions that practices have in place. There's a use of scribes that can help alleviate some of that burden on providers. There's also right now, scribes are very much used in EMRs, at least in California, in EDs, at least in California, but expanding that use in other specialty areas and expanding team-based care. So if we're thinking about in terms of like clicking and all the clicking that kind of is involved, there is something here which is a more short-term solution of having someone else helping to do the clicking. And then if we talk about automation and standardization, this is improving the experience for the end user so that there is a reduction of clicking. So, really understanding workflows, improving workflows, having tailored interfaces, which some healthcare organizations do really well. I've heard Kaiser has one of those systems that really improve the end user experience. And really standardizing tools within the EHR so that they're easier for providers to use. And then finally, if we're talking about reducing those clicks, and then how about interoperability for population health? What that could do is really take that information, have it entered once, and then it's there for the whole health system to be able to use. So, any investments in interoperability that we talk about, I think are an important consideration for how they can be used in population health. And so, I just wanted to kind of end with interoperability. If the sort of idea of what interoperability is great, the ability of different information systems and devices to access, exchange, integrate, and use data in a coordinated manner to optimize the health of individuals and populations globally. I mean, we are pretty early in our journey on interoperability, but there are so many positive things that I think that are right now either in place or are areas that people are working on, even at the CDC. So really, presentations like this, I hope, really show how we use data to drive care and public health. There are public health use cases that different organizations and work groups are looking at within the CDC. There's also SGOH standardization, which I think is an important part of what we're talking about here, really being able to take that data and standardize it. And of course, it would be great. I've heard conversations about patient identifiers as well. So one patient identifier, which would help sort of clean up that data as well. And those are some of the areas that I feel like are potential positives that are coming down the line. So that's it for me today. I hope you guys enjoyed that. Any questions?
Thanks. This presentation is now open for questions. You can enter your questions in the Q&A box, and we can start to get through them. Samareen, did you want to read off the questions? We already have some that are piling in.
Sure. Okay, so there's one question on how will the new state Medi-Cal population health management system serve your health plans and healthcare delivery systems to in turn serve patients? What value add is there for the new state system above and beyond what your health plan is already doing with your population health management data? This is great. This is a great question. I think that the way that we see it at our health plan is we're a little bit ahead of the state. We have a risk stratification strategy already. And what the state is doing is building their own. So in July of 2023, they're going to have their own RSS strategy, as they call it. And they will be asking us to use that and then layering our own data on top. Now, the thing is, we are a little bit ahead, but there are other plans that don't have RSS strategies or risk stratification strategies. So that is definitely a big boon for them as well. It's a little more complicated for us because we have to kind of adapt. But the other thing that the state Medi-Cal is doing, of course, there's a lot of funding. There's a lot of support. There's a lot of, I'm not going to say that there is no value add there in terms of what, the kind of dollars that are associated with helping people, especially those who are homeless, who have food insecurity, things like that. But one of the other value adds that I am very excited about and really excited to see happen in California is something called PHM service. So apparently they've just they've done an RFP and they've got the vendor for this, and all the health plans are anxiously waiting for what PHM service looks like. But it's a place where apparently they're going to be able to put all the data on members and allow the members to then edit that data. So anybody who has a Medi-Cal with one of the health plans, and I believe state Medi-Cal as well, would be able to go in and change their data. And then we hope that there's a potential to add other data sources that we don't currently get, such as on SOGI data, so sexual orientation and gender identity data. We do not get anything on that. We are hoping that that will help. And PHM service is kind of, it seems like one of these great ideas. We'll see what it actually looks like. But there is a lot of value add. And when things come down from the state, it also helps our providers to also know that this is an important part of what health plans will be doing. So what we get is an all plan letter, an APL, and that really defines what services we're going to be offering. And so it really gets everybody primed for the same kind of work that we're doing. So I know we're doing a lot and we always think that we're a little ahead of the game, but having that backing from the state does also really help. I hope that answers your question. Okay. Sorry, it keeps moving. What health plan population health data and management data information or action orders come back into the EHR to be seen by providers at the point of care or during patient visits, or is this future state? Okay, this is a great question as well. This one, we do have that care gap sort of analysis. So much of that is us feeding back to the providers with where the care gaps lie. For example, I'll give you cancer screening. We have metrics that we track for that, and we provide our providers with those care gaps so that they can see on a member level which members have not been in, for example, for cancer screening. There are, of course, improvements that can happen in the future state in terms of what that data looks like when they get it, and how easy it is to feed into different EHRs. Some people are able to do it, but we still have very small providers who aren't necessarily able to see that and still rely on paper charts and things like that. But that is an area of improvement. The letter that I talked about that we did for asthma, that some folks were able to somehow translate it into their EHR. I believe it just comes up as a scanned document, unfortunately, but that is something in the future state that we would like to help with. We do help with the panel as well, showing, like I said, where the care gaps are and things like that. Okay, I'm curious how you might be impacted by CMS's recent letter on allowing innovative interventions. Their SDOH example was providing diets for patients who require an expensive or limited diet for their health. Do you have support interaction with your state that would allow a pilot in this area? It would be exciting to see greater adoption of housing and food insecurity screening, and if your data could be used to support upstream SDOH interventions. Yes, I haven't seen that link. I'll take a look at that link as well. So yes, that SDOH data is actually quite critical in impacting where our innovations and sort of our interventions will take place. So for example, especially with some of the housing and food insecurity screening, as you said, once that screening and once that data comes through, that's really where we feed back to the state on what we're seeing and how we would like to sort of adapt those programs. So yes, that is definitely something that we think that will be coming through, and that the better the SDOH data, the more of that we'll see. But again, I think the key here is how good or how much better our SDOH data can get, and how we do those screenings to be able to take that data and then feed that back to the state. And the state is pretty much, in terms of what we do have a lot of leeway in terms of what we're allowed, especially in terms of pilots. So that would be something that we would do. But again, the better the data, the more we have to kind of push for. Thank you for such, thank you. A few questions. Are you able to look at community level housing and food desert data to share proactively with the provider? Does your health plan reimburse for SDOH elements looking for food prescriptions? And how much can you, your health partner with your community to address and remediate root causes of disparities? Okay, yes, so quite a few questions here. That's the thing about local health plans in California. We have really strong relationships with our county and with our community, and we really do try to get to the root cause of those disparities. There's many ways that we look at that, and we do, so in terms of food prescriptions, I think you mean medically tailored meals and things like that. We do actually cover that, and we have vendors who provide those services as well. And in terms of housing and food desert data, the thing with our county, you know, it's located between San Francisco and you know, Silicon Valley area. So it's a although we do have some food deserts, and I would love to show you this chart that we have that has our entire membership, you know, through geo mapping, as well as where our providers are located, and then other things that are available and resources that are available. That part is, it's really the housing portion of your question, and that is the issue as well. And so yes, we are looking at all of those things. Our county is very proactive in terms of what they want to do for housing. So I mean, I think I'm addressing your question in different ways, but yes, we are doing whatever we can to remediate those root causes, as you said, and really looking at those disparities. And housing is a huge focus. We also have funding now that the state has given us, which is literally just for housing and how we can improve that. And we're also hiring for that position as well. So this person will be looking at how we sort of fund that program and how we use those dollars. Oh, okay. Slide 21, can you repeat what the acronyms refer to, such as AMR? Okay, so this is really getting into the technicals here. AMR is the asthma medication ratio, which it looks at how well controlled their asthma is. BCS is breast cancer screening. I think you probably saw CCS, which is cervical cancer screening. There's PPC, which was prenatal care and postpartum care. Those are just metrics, and those are the metrics that were kind of given to us by NCQA and other organizations that we have to kind of report to and who audit us. such as DHCS, but there's other metrics that we look at that we also create for ourselves, such as gestational diabetes, which is a problem within a specific population within our membership. So, I don't concentrate too much on those because they are pretty detailed, and how people fall into those categories is kind of varied. But the point was really that we do have these metrics, and then we try to really break down what we do with those in terms of some of the information that we have. Okay, do you have the patient's work information? Does your asthma management address work exacts? No, and this is actually a really, really important part of what we don't have. One of the things that we do not have, and many of the things that we don't have as health plans, is where the members work. We can get this sometimes with farm workers, and that is a part that we definitely do look at, especially for asthma management. We also know sometimes, generally, if especially for children, how many medications they're on that are controller medications or other kinds of medications, and that kind of determines to us perhaps what the household looks like. We also have some information on the size of the household, but that data is not perfect, because that household data would also be important, as you said, and having the patient's work information would also be interesting. We have tried to get this data again and again. There are so many security issues associated with that, and that's what I was kind of talking about, a patient identifier number. That would really help in like kind of linking all that. But I think there would be serious issues with sharing that data. One of the other things that we wanted to do in relation to asthma in the past is we wanted to make that connection with the schools, so that the schools knew which members were not doing well on their asthma measures, but we weren't even able to share that information with schools, and we were having to go through providers, whereas where we have that data information exchange sort of partnerships, but that was pretty difficult as well. Okay, risk stratification, what is UM usage, and what if a person is low UM and high acuity? Wouldn't that be a higher risk? It kind of depends. Okay, so UM is utilization management. It really depends if the person is what kind of high acuity they are and what conditions they have. So if the conditions can be managed by their PCP, or that we believe that they have other supports, then they wouldn't necessarily fall into a higher risk category. Are there practices for using EHR for population health? This is a difficult question to answer, because it depends on where you are and what access you have. The best practices are really those certified EHRs. Unfortunately, they work well for population health. Also, one of the things that I've been learning, speaking to other folks, was what are the relationships that you have with kind of your health plan? If you are a physician, what data can they kind of help you get, or what can we do? As Medicaid is great because there's a lot of innovations that are coming down in different states. So what are they doing? Best practices might be to kind of reach out and see how all the health systems kind of interact in terms of using those EHRs effectively. Please feel free to, if you want to ask more, I can answer there as well. Did you connect with the AMRs directly or utilize an H? So this one is, we have access direct to some of our providers, so we get that information directly, and in some cases it's varied. In some cases it doesn't come in directly, and in some cases we rely on paper charts to kind of verify that as well. Of course, that is much more time consuming, because we still have providers who are not interested in moving to digitized records. About leveraging with respect to patients' SCS, what are the novel approaches that have been implemented so systematically later? Okay. Okay, so what is going on there is, first of all, I think standardization is an approach that we need to have in terms of SUH, and that is happening. I believe it's called the Gravity Work Group at CDC. Please, someone correct me if that's not true, but they are working on standardizing those SDOH metrics and how to collect them. And then what we do is really trying to, and the new thing that we're kind of doing as a health plan, and I'm sure lots of health plans are doing this, DHCS or the state is releasing what they consider the top 10, 25 SDOH measures that they would like us to work on or to be able to collect that data. So what we're trying to do first is we are going to try to standardize the form that is sent out to our providers so that providers are not having to fill out like 1,000 forms just to figure out what's going on, that answers those questions. So there's definitely some standardization, and these things are not innovations really or novel approaches. They're just really common sense approaches to how to collect this data. And then finally, when we start seeing this data, and we have seen this data really increase ever since kind of DHCS has released an all plan letter and asked us to do this. But what we plan to do later is, once we have a sense of how good that data is and what providers are able to collect, we are hoping to tie some incentive dollars to that as well, so that if you do a screening, and hopefully it's a good screening and not just a quick one, and that's one of the things that you have to always check, but we want to tie some pay for performance metric dollars to that as well. But that's something that we are considering as well. One problem in our system is how the data is handled when it's sent back to providers. Providers have full schedules already and then get lists of patients with frequent ER visits, patients not meeting goals, not filling them. I'm concerned about individual clinics and individual providers' capacity to respond to this. Yes, it's really based on a clinic by clinic. And we do, okay, so what we're trying to do is trying to help our providers really have that support. And I think part of that might have to come from us as a health plan, providing some sort of financial or staffing individual to help take that information and really be able to use it. And partly that sometimes is just someone at the main office, someone in admin trying to help collect that data. We are seeing that is one of the biggest issues that we have when trying to work with our providers, that they just do not have the staffing or the resources to be able to do that. And trying to figure that out and trying to support them is really the crux of what Health Plan of San Mateo is now kind of working on for the next few years, and investing in especially in our PCP network to help support those things. Some providers do it really well. So we have a few providers who track these things on a regular basis. They take their data and they've streamlined it enough, and they work with their quality teams as well to try to take that data and input it back to each of the providers in that hospital. And that has worked really well, but then it's consistent, right? And they always come back to us with, we need this better, we need this cleaned, we need this, and really working with us to try to understand where the gaps are and what they can do with us. And in some of those areas, what really helps is having a champion. So a lot of the improvements that we've made in asthma for the pediatric population has to do with a champion at one of the larger FQHCs who is really feeding back to me constantly, your asthma action plan sucks, it needs more colors, it needs more this, and really helping with that. And then taking the data that we show them and say, okay, this is the data that we have available. And she would look through that data and really tell me, I don't need this, I need vaccination information, I don't need this, take this out, So really tailoring it to those hospitals so that it's actually usable, and of course providing some level of support there. So we try to do whatever we can on our health plan and to try to mitigate some of those complications, but those are actually really, really good and true issues that we face. Have you found a good way to pull out people with disabilities, like as a demographic? Yes, that is a population that we work with. So Medicaid has aid codes. So it will tell you how people qualify for Medicaid, and it's a similar kind of thing for Medicaid, Medicare. And we do have so there's someone in my team who actually, we have people who work on perinatal population, in particular, children and youth health is the other one, and then seniors and persons with disabilities, which are sometimes combined, but they're actually very different. We do a lot of work in trying to figure out what is going on for the people with disabilities. So we look at them, yes, exactly as a demographic. We take them out of the category of seniors because when they're in Medi-Cal, Medicare, sometimes they're lumped into these categories, but they have very different needs. And we try to understand those needs. Those are both physical disabilities as well as sensory, as well as behavioral health as well associated with those. So we do a risk stratification by disability status as well. And we're working very closely on many of the areas that we talked about. So we do any intervention that we're doing, we try to, especially if it's a disability, if it's a metric that would be influenced or affected by a disability status, we try to take that into account. One of the areas that we are working on right now is cervical cancer screening, for example. And so for that, we are really, our risk, our sort of, you remember that disparities thing I was talking about? I actually took out that part. But race, ethnicity, disability status is also one of the characteristics we look at, and we see a huge disparity in cervical cancer screenings. So that's one of the areas that we would like to work in. It's not easy because some of our providers just do not have the funding or the ability or the knowledge to deal with some of the complications that arise from that. But what we're hoping to provide is some funding, some knowledge, and hopefully the data to back that up. So how do you collect data on SDOH factors? Again, right now what we're doing is we do have some member level reported stuff that comes in through various surveys, which really when your surveys are in the forms that they are, it's not that easy to link it back to our data. But the best way to do that is through this sort of LOINC codes, or like in what we use are Z codes. So at the point of care, if they're screened, there's specific Z codes that we encourage our providers to use, and those Z codes are what we then take on and we incorporate into our various analyses through the informatics team, and they do their magic and it comes out and shows up what it is. But really it's the Z codes that we're going to be relying on pretty heavily going forward. PHM service is Population Health Management Service. I don't know why it's called service, because the other thing is called PHM program, but you know, maybe we'll find out. What is your denominator? At one point you mentioned all members, but we typically associate that with claims data. So how do you determine the denominator for clinical EHR data? So at one point you mentioned all members, but we typically associate. Okay, I don't know exactly if I'm going to be answering a question. Your denominator is different per population. So it will vary depending on what we have available in terms of, okay, I think what you mean is all members. Okay, so our members are members who are part of our health plan. So, you know, they have to be kind of we pay for their services, or they are members within our health plan. And that's really our denominator. And then, so we look at EHR data, like suppose we're looking at breast cancer screening, for example. So these are all the members who are part of our health plan who qualify for that particular metric. And then we look at the numerator in terms of what is coming in terms of EHR data, or, you know, clinical data, or whatever it is that we're looking at. Patty, thank you, Patty. She really helped me with my presentation as well. As a health plan, do you incentivize your, yes, we do. Yes, so we do, we will. That's what I should say. We do incentivize our providers to enter SDOH data. We want to, again, so with the way we do that is we have P4P, which is pay for performance dollars that are associated with different metrics. And we want to add that to SDOH data. But before we do that, we want to ensure that the data that we're going to be collecting is going to be valuable. So for the first year, it's going to be a reporting metric. And then hopefully that will help us make that decision on whether or not we will provide that incentive. Can you use EHR data to track SDOH over time for bees? Yes, that is one of the aims that we're trying to check. So we want to see how those things improve. And again, part of that screening tool is taking that screening tool and then doing that again, and then seeing what the difference is in terms of what's going on with our members. Now, sometimes with some of this data, especially right now when it's a little bit smaller, we do rely on those resources, but we also then contact those members directly to see if there's been an improvement. And that risk stratification that we do constantly we are required to also, but we actually do this. We reevaluate that on a monthly basis so that members could fall in and out of that risk stratification category, high, medium, low, depending on how well we think that we've kind of met their needs. Or, they probably, maybe they don't have asthma anymore or something like that. But so that's what we try to do. How do we improve SDOH? We are very much in the early part of this, but we have made significant improvements for housing for many of our members. So I can tell you that on an anecdotal basis, but I don't think we have the data to prove that yet. But hopefully you'll see all these changes within CalAIM and California, and hopefully over time. And then we would potentially track SDOH over time using that information, but we would do it at the health plan and hopefully be able to share it. Since patients want to hear from their provider and not their health plan, what are some suggestions for balancing the benefits of provider outreach with more automated approaches? Portals are great, but what about POPs that are less likely to read a letter on the portal? So this is a really great question. Having the health plan have access to appointment information would also be something that that really helps. So for one of our interventions, which is well care for teens, that's one of the things that we would love to help with. We haven't gone there yet, but one of their issues is they want to talk to their provider, but they just can't get an appointment. And the reason they can't get an appointment is because staffing at the provider site is not great. So if we had access to that, and we're working on that, we're trying to get some ideas around that. If we had access to those appointments, we would be able to do that. The other thing that we do is sometimes some members, there's certain areas that members will not speak to their health plan, but there are certain areas that they will. So really figuring out what it is that they will talk to us about. We have a diabetes prevention program, for example. They are more willing to talk to the health plan about that. They're also more willing to talk to us about their prenatal and postpartum care because we provide a gift card, and that has really helped. And our portals are not very well used at all. So we do have a portal, but it's the usage is very low. So that hasn't helped. Those are some solutions that we've come up with. How do you use the social determinants of data from EHR to inform clinical decisions? Again, some of this data is newer, and we're still building those things. But some of the things that we want to help providers understand is what the composition of their panels are. So if we feel like there's a lot of members who have disabilities or housing support issues or food insecurity, that's data that we would like to directly inform our members about, our providers about. So that's the kind of data that we would share back with them, and hopefully help them understand what we could do for them as well. And really also sharing with providers what the programs are that are available so that providers are not having to look for things. So, there's medically tailored meals, for example. Once we find some food insecurity and that person has diabetes, that's one of the programs that they could refer their patient into. Does your health plan pay for housing if a homeless patient is currently in hospital but no longer? Yes, we do have that. We have this program that does provide a level of care until housing is found. So yes, and we have many individuals who are involved at the health plan in that area as well. Okay, thank you, Crystal. Thank you for sharing that. What are the potential implications for one can use longitudinal data from EHR? I think there's so many things that we did even during the pandemic, trying to see that what was going on with the population, and trying to trend that data over time to see where we were going with that. There's also so much we do in terms of tracking different chronic conditions. So those are just some of the areas that I think that we use. I want to try to get to. people move in and out of the health plan. Yes, that is a great point. What denominator you use then or adjust for that, that is really the crux of some of the issues that we have. Not only do they move health plans, once they move, they go to another health plan. That ability of that data to talk to each other is probably the biggest weakness that we have. So, constantly we are adjusting for that regularly. So we do know what that denominator is, and that will move over time because people do move in and out. But our ability to get that information is not perfect. We then use the denominator depending on what the metric is. We're still adjusting for that on a regular basis. I'm curious. And by the way, one of the interoperability things will be, at least in the state of California, will be trying to get all that information on the health plans so that you know where your members moving and what's going on with them and what screening they've already happened. Yes, Gravity Project, exactly. Regarding your comment about STD screening user basis, I'm curious if it's also coded into the. Yes, they are. They are. That'd be great to share with public health. You mentioned yes, so I hope you mean. Yes, and part of the Gravity Project, and from what I'm understanding about the Gravity Project, is a lot of it is standardization, which I'm really interested to read about. And again, using public health as a use case for interoperability, which is a little step behind population health, but really in the right direction. Yes. Do you think there will ever be a universal communication system? Well, not in the United States, where we have such a fragmented payer market that although there is that dream, I think that what it needs is really an investment. And who is going to be making that investment? Are we working with the right people, bringing the right people to the table? This is such a big question, and really where the CDC kind of comes in. What are we going to do to have all those things talk to each other? A lot of it, I think that data is available at various places, but this is a really big ask, and I think really that would be so great if that was where we were moving. But our system is very fragmented, as we know. Do I think there ever will be? Maybe, but I think we need a lot of funding and a lot of these kinds of questions being raised and asked to make sure that we are asking that question from the right people, involving the right people, and moving towards like small changes that will get us there. And one of the things that I said, that Mark Twain quote that was there, really, understanding what we want our data to do so that we start from this place where we're planning it rather than just implementing. And I think there's so many things that are out there, such as the Gravity Project and other projects that are moving us in that direction. But it seems very, very difficult.
Well, thank you, Samareen. We're out of time, and we answered a lot of questions. Thank you for the presentation. That ends today's Preventive Medicine Grand Rounds. And please join us for our next Preventive Medicine Grand Rounds on Wednesday, February 1st. Dr. Joy Su will be presenting on artificial intelligence in health and healthcare. We look forward to seeing you in February. Thank you.
Thank you.